Hi guys, this is Renee. For this voiceover, we're going to talk about muscular dystrophies. Muscular dystrophy is a progressive, degenerative, and inherited disease. They all vary in pattern of inheritance and their age of onset. Most cases of muscular dystrophy are diagnosed in early childhood. While there are many different kinds of muscular dystrophies, for this class, the one we're going to be focusing on is Duchenne's muscular dystrophy. So as I said before, there's more than 30 different types of muscular dystrophies. The one we're going to focus on for this class is Duchenne's muscular dystrophy, which is the most severe and the most common type. It exclusively only occurs with males, and it is X-linked, meaning that it passes from mother to son. Muscular dystrophy results from a mutation of genes that encodes a dystrophin, which is a protein product in skeletal muscles. In children with muscular dystrophy, we're going to see a complete absence of this protein. Not having that protein results in a progressive weakness and wasting of symmetrical groups of skeletal muscles. Over time, the weakness and wasting results in disability and deformities. Early on in the disease process, as the muscle fibers begin to degenerate or fall apart, they begin to leak the protein creatine kinase, and they then begin to absorb excess calcium, which results in even further damage to the muscle fibers. Muscular dystrophy is often suspected on the basis of clinical manifestations. It is diagnosed by doing a muscle biopsy, electromyography, and testing the child's blood level for creatine kinase. Creatine kinase levels will be elevated early on in the disease process and will decrease in the later stages of the disease. It is important that parents and siblings of a child with muscular dystrophy are recommended to have genetic screening and counseling. Children with a positive family history of muscular dystrophy are at very high risk for developing this disease and need to be monitored very closely. Muscular dystrophy clinical manifestations usually present between the ages of 3 and 7 years old. As a nurse, what you're going to see is a progressive muscle weakness, progressive muscle wasting, and contractures. You will also see calves that are hyperatrophied, so they will have large calves but will have very little strength because the muscle lacks the strength due to the wasting. Unfortunately, these children do have a loss of ambulation, usually between the ages of 9 and 12 years old. This is a relentless and progressive disease, and usually as adults they die from respiratory or cardiac failure. Life expectancy with muscular dystrophy varies depending on the specific type that a child may have, but usually it's not uncommon for them to reach early adulthood. As nurses, when we watch these children ambulate, it is common to see a waddling, wide-based gait, enlarged calf muscles, as I mentioned before. We'll also see hip and knee contractures, foot deformities, scoliosis, lordosis, moderate obesity, cognitive disability, and cardiomyopathy. A common maneuver that we're going to see in children, particularly with Duchenne's muscular dystrophy, is the Gower maneuver to rise from the floor. And you're going to see a video of that on the next slide. So classic finding with children with Duchenne's muscular dystrophy is the Gower sign. And this is seen with children who are in a squatting position and have to use their hands and arms to walk up their own bodies and pushing as they go in order to stand up. This is because of the weakness in the proximal muscles, the hips and the thighs of the lower limbs. I've included a video here. This actually gives you a really good idea of what it looks like. This is just a picture to help you see some of the common clinical manifestations of this disease. You'll also see the posture that you'll see in these children. Common complications of muscular dystrophy include contracture deformities, atrophy of disuse of the muscles, infections throughout the body, obesity, and they're already at risk for being overweight with this disease, and then cardiac and respiratory manifestations. We really need to monitor for any signs and symptoms of infection, as these children often die of cardiac and respiratory complications, so we don't want any infections spreading to their heart and lungs. Unfortunately, there is no cure for this disease, and there is no specific treatment. Early therapy is aimed at maintaining function in unaffected limbs and muscles for as long as possible. And we can do that through range of motion exercises, which can help prevent contractures, which can also lead to decreased mobility. Surgery, bracing, and physical therapy can also help to increase this child's mobility. Our goal is to maintain their independence as long as we possibly can. Later therapy is aimed at maximizing sitting capabilities, and that's because past the age of 12, these children can't usually walk on their own. So we want to focus on their ability to sit. We also need to focus on respiratory and cardiac function and on their self-care because, again, we don't want them to be, completely dependent. We want to keep them as independent as possible. We also want to prevent any obesity in these children and have prompt attention paid to any infection they may have. One of the main goals of treatment for these children is to prevent contractures. As I mentioned before, treatments for contractures or preventing contractures include range of motion exercises, braces, and also the tendon release procedure. Muscular dystrophy, being a progressive and incapacitating disease, makes it very difficult for families to cope with. Clinical goals for these children and their families are going to be to preserve mobility and independence. Sometimes parents need to learn how to balance limiting the child's activity and doing for them versus allowing them to accomplish things on their own. Treatments that support clinical goals are physical therapy, orthopedic appliances, and family counseling. As nurses, we need to help these families cope with the disease, provide coordination of health services, and anticipate future needs. We also need to know that we understand that we know the clinical outlook for these kids, but we need to be sensitive and knowledgeable when talking to these families. And we should also recommend genetic counseling for parents and siblings. So when coping with impaired functioning, basically our nursing care needs need to focus on keeping the patient active as long as possible, providing skin care when the client is immobile, and we need to provide maintenance care throughout their life. We're not going to be the only one providing this care for these children with muscular dystrophy. We also need to teach the families how to do these things. We want the family to help the client in the later stages of muscular dystrophy, to reposition them every 2 hours, to prevent skin breakdown. We want to make sure that the clients are getting adequate fluids. We want to make sure that they're on a bowel regimen. We really need to protect these children from sick individuals, so we don't want them around anyone who has any respiratory illnesses. We want to encourage pulmonary toileting and respiratory exercises, and we want to make sure the families have wheelchair-accessible houses. As nurses, we need to make sure that we are using resources to help these families with newly diagnosed children. We can do this by providing families with a list of support systems. One of the main support systems is the Muscular Dystrophy Association of America, and what this does is provide guidance and support for these families. So this concludes our voiceover for muscular dystrophies. If you guys have any questions, please feel free to reach out to me.